Much like the domestic partner regs again, great example. The insurance division in the state of Oregon looked at insured contracts as where they were going to get compliance. I think the federal government looks at insured contracts as where they're going to get healthcare reform compliance, and they're not really sure what to do with self-funded plans yet. So the FAQ guidance, as I said, external review, July 1st, 2011. If you have an insured plan in Oregon, you have to do this anyway. You may establish residency or qualifications on dependents other than the children dependents. What that means is you can still cover a grandchild or a niece or nephew and require them to be an age or a residency or an income limit. You'll remember the age 26 dependent just said, are you a child? No more dependent, no more do they live with you, no more they need to live on their own with 2 kids and a house on their own without it mattering. But you can still put those in on non-children dependents. Changing tiers or rescissions. This is another good one. You guys all know the concept of rescissions? Okay, the idea of rescission says I can't take away health insurance from somebody that has it, that I enrolled unless they fraudulently told me something that led them to be enrolled. So this happens a lot in the individual context. I had a knee injury, I didn't disclose it to you, the insurer then kicks you off because you didn't tell me you had a knee injury. Or you told me you were 34 and in fact you're 64, whatever. So if you're fraudulent, it's impacted group health plans. Why? One, there's a lot of misinformation out there, particularly on dependents, that says if somebody says, yeah, it's my dependent, and it turns out to be their 55-year-old father out in Hillsborough that's working and you just covered him on the Xenium Health Plan. Not that Brandon would do that. Then we can't kick this person off. So you need to go audit your dependents. You need to go check everybody out. If not, you're always going to have these guys on your plan. That's not true. You are allowed to kick people off your plan when you figure out that they're not eligible. What you are not allowed to do is kick them off 6 months retroactively and then somehow recoup claims dollars or something else that you paid on their behalf. The greatest example of this is COBRA. If we couldn't kick people off a plan that we enrolled, we would have no need for COBRA because we could never kick off a departed employee. Why? Because we enrolled them, it wasn't fraudulent, and they're on the plan. So it's a good example why this rule gets misunderstood. Rescissions means backward coverage, and that's the individual market. I will now no longer cover your knee injury that you went to the doctor 6 months ago because you lied to me. Not a group health plan issue. I see that misunderstood a lot. Changing tiers will require a comparison to previous tiers. This means you can't game the system by saying I'm trying to remain grandfathered by having only a 5% or so cost difference. And so instead of having employee only and employee plus spouse, I now have employee plus 1, plus 2, plus 3. And I'm going to jack up my rates on those pieces of the coverage and still remain grandfathered. You can't use different tiers to change. If you have the tiers you have today, whatever you change to will be compared back to those tiers. So it's just preventing you from gaming the system of cost. This is really what I think is the most important, although it affects only a few people. So dental and vision plans. We all know in the rules that they were exempt. But then we get this FAQs that says, wait a minute, they're not exempt. They're only exempt if we consider them not integral or they're a separate policy or certificate. So what does this affect you? Self-funded plans that say, I don't really care, I just cover everybody's claims. And 2, combined medical and dental. So I go to Kaiser, for example, or ODS, and I get a medical and dental plan. And I charge employees $400 a month, and if they enroll for medical, they get dental. The government considers that dental plan to be healthcare reform applicable. Which means what? I have to put cost sharing in, and I've got things like pediatric dental caps that I can't put on, which impacts what? Orthodontia, primarily. So now I've got to cover every 19-year-old that needs orthodontia. Why? Because it's part of the health plan, and I can't put limits on children's health care expenses. So what do you have to do? If you're a self-funded plan, you have to write separate documents, and that's ridiculous, but it's real. You're going to have to or you can put in cost sharing. Charge people $1 for all eye care, but show that the dental plan is a separate animal. But if you have them under the same contract and you don't have any cost sharing, then you have coverage for all those things and all those limits apply. So it's an unwary trap that I've seen recently. The administrators have been very good about catching it, but the employers are universally confused about why it exists. The other way you can deal with this is things called preventative limits, meaning you could put provisions in your plan that say something to the effect of, I only cover what's essential or preventative, and then I'm forcing the orthodontist to say, these braces are not cosmetic, they're actually preventative of something. And as you can see by my teeth, Mike Rook could be, I never had braces. So. And again, having a bad personality but a great smile, right? No? Tough audience. Grandfathered plans, the only other piece is that if I screwed up grandfathering, I didn't realize it. So I've got a terrible broker, i.e. from Fullerton, for example, in mind. And he comes in and he gives me a cost impact analysis. He says I'm grandfathered. And he's totally wrong because he can't do math, because he doesn't have a 4-year-old. He doesn't do 1, 2, 3, or what's 3 gummy bears when you lose 2. You get 1, and then you cry because you're mad because you only have 1. So Mike, I pull that trigger, Mike, especially if I'm going to watch. Let's do math with your grandfather. Here's you have 3, now you have 2, and you have 1. Yes, you have 1. Now you get 1. She doesn't like that. So he messes up, he sends in your contributions, you're wrong. You're allowed to come back and change it back and say, I didn't realize I was incorrect. I can still be grandfathered. So effective now, what do we care about today? We care about these issues. We care about whether or not we impact grandfathering. And a lot of people, I think, are scared of this concept of grandfathering. I hear it all the time from clients and friends. I'm really worried, I want to remain grandfathered because I just don't know. Kind of your question, David, of, well, what happens? I should just remain grandfathered if I can, because that'll keep me out of everything. It's really not true. Grandfathering really only means a couple of things. External review, what's most important, I think, non-discrimination, and no preventative cost sharing, which a lot of plans, especially at the small level, don't do any cost sharing anyway. Non-discrimination is the main issue. If I cover, and I think restaurants are the prime example of this. I have 8 run-of-the-mill employees. I pay a general manager $125,000 to run the restaurant, and I'm a guy who owns 4 of them, but I don't really work in any of them. One of my clients, Pop Murphy's Pizza, has this problem since they have a lot of franchises. Guy owns 8 of them, hires a GM to run 4 of them, and has a bunch of high school kids earning $6 an hour, or whatever their wage is, $8 an hour. It's amazing how much that's gone up, by the way. I think I earned $4 at this place in Hillsborough right by Hill High. And I thought it was big money at the time, trust me. I was glad to have it. So anyway, they have their general managers. How do I cover just that person without covering everybody else who doesn't want it anyway? So those are the kind of companies I think really truly care about non-discrimination. Most you can pass, as we found in my example, if you just really dig into how to pass discrimination. If you're an go ahead. Question?
I want to make sure that you're going to say what external review is.
Oh, yeah. Does anybody have a self-funded plan in here? Anybody have a self-funded plan?
Partially.
Partially self-funded, so a Great West type contract or something. So what external review is, and people don't have claims much, but when you have a claim to your medical plan, it's more and more often today. So external review is a 3rd level of appeal. So I get my EOB, my explanation of benefits, and it said I'm covered 70% because I went to a doctor who's not in network or something. And I go back and say, wait a minute, I called you and you said this wasn't in network provider. And they say send an appeal. So they send in their appeal. Your claims administrator or insurer covers that appeal. Then it comes back and they still deny it. I'd go back and appeal that appeal. In Oregon, I have this 3rd level, which is external review, that says I contacted the independent review organization. They will come up and look at it without being the insurer and say, do I agree with this or incorrect? Now, what you are seeing in claims, which matters to you, I think external review matters, but it doesn't come up all that often, is you're seeing a lot more doctors who are having assignments of claims to from participants who are trying to go then get the money out of you for your repricing schemes by the insurer or self-insured contract. Meaning, I think that the insurer is cramming me down on my knee surgery unfairly. And I think I owe more. And so I get the participant to assign the right to me because I know I can't get the money to the participant anyway. So I'm just going to write off that 10 grand. And I'm going to go file suit against the plan or allege an ERISA violation. Send to you, plan administrator, because you're all the plans administrators, whether you like it or not. Send me a bunch of documents and about the repricing, to which you read and say, I'm not really sure what that means, I'll get to it. Then you wait 90 days to answer. Then all of a sudden he's got you an $110 a day penalty for not providing the SPD timely to the ERISA participant, who's the doctor now, because the claim's been assigned. So you just have to be mindful about claims today, about when they're processed, when you receive stuff. And you have to ask the question once in a while of your insurers and administrators and consultants of how do we know that a claim is being processed directly? Because particularly in a self-insured plan, if you pay for it, they're going to err on the side of you paying every time. So you just have to be aware of who's making the decisions, what are the decisions, what are your loss ratios, are they correct, etc. Lifetime limit, lifetime and dependent enrollment periods. What this means is if I failed a lifetime limit, so you had my example of Charlie, the kid who had tragic leukemia, was lifetime limited off the plan, I have to go back to those individuals and say, guess what? We have no lifetime limits anymore. You're allowed to come back on if they're still eligible. Dependents are the same way. If I kicked off a 25-year-old dependent or 24-year-old dependent a year ago, now they're 25, I have to go send them a notice and say, you're welcome to come back on. The lifetime limits or restricted annual limits mean I have to take those off of my plan. Most people are just putting in annual limits for year one and figuring out what they're going to do next year. So if I had a $1 million lifetime limit before, I'm making that an annual limit today, and then saying I'm going to figure this out in 2012, what to do next. Because I know I won't have any further dollars. And no pre-ex exclusion for under age 19, which is pretty standard. How many of you are still with me? How many of you are here in the room today? Okay. I know it's complicated, so. Non-discrimination test, because it's important. I get this question a lot. This is an eligibility and benefits test. So if you have insured plans and you're not grandfathered, which means if you're under 50 lives, you're almost certainly not grandfathered anymore. And if you're over, you're going to lose grandfathering eventually, because every insurer I know is going to say exactly what Pacific Source said, which is I'm not building a system for every client who's one wants to have a pre-ex, one doesn't, one wants a lifetime limit, one doesn't. They're going to develop one software system and say, get in. You're all non-grandfathered. So you're all going to get there sooner or later. Different premiums. I get this question a lot too. How can I can't charge different premiums to employees because that violates non-discrimination now. That's not true. If you want to charge different premiums to your employees, you can do it as long as you don't violate Title VII. But you have to have a bona fide business reason to do it. So if I want to charge my hourly employees, for example, 70% to pay for their insurance, and my salaried key employees to pay 30%, it is allowable. You just have to pass ERISA and HIPAA, really, to provide for that.
An example of business reason would be?
Key employees, their
This classification.
classifications, yeah. So my business development director, for example, an esteemed institution of Xenium, deserves to have a higher healthcare premium than, say, a run-of-the-mill, you know, HR rep or something. Right, Brandon? True. He told me that earlier. It's on tape. So it must be true. It's on TV, it's on tape. So you have to have different classifications. So a lot of companies don't understand that. I'm not saying I recommend different premiums. It makes people angry. It causes a lot of strife. There's a lot of legal potential in there of why am I doing it? But it is allowable. And it's probably the most frequent question I get. My consultant or my insurer told me this could be discriminatory, seek legal advice. I'm glad you did, but almost always it's allowable, because rarely is it, this is my friend, and I paid nothing, and these are two guys who filed a complaint against me last year, so they pay 100%. It's generally not for those reasons. Bona fide business classification. You are going to see a lot of executive arrangements that are going to have discrimination problems, but only if they are non-taxable insured plans. These are your executive care policies that consultants were selling that provided additional benefits for executives under an assured concept. What almost every business is going to go to is they're going to move from not these pre-tax issues to post-tax boutique medical claims, basically. Most executives at your companies care about access to their doctor. They're not so worried about having coverage for something in and above something else. They don't want to have to wait 3 weeks to go see a doctor. What's the biggest impact to healthcare reform? As I said, individual access. What happens when I provide you all guaranteed access? All of you go to the doctor. Have any of you guys ever put in a dental plan before? You? When you put in a dental plan, the first thing everyone does is they go get their teeth cleaned. Because they haven't been in 3 years, they've waited, they've been in lines like you saw at the convention center. And the first year you have horrible, horrible experience. And then everybody remembers why they didn't go to the dentist, they don't go again. But that first period of time is going to have a lot of people at the doctor. That's what your executives are looking for. These boutique practices are going to go absolutely bananas. The other issue is going to happen is you've got a lot of doctors who are going to say, I don't want the Medicare and the new medical loss ratio policies anyway. I'm a really good doctor in a specialty. I'm not going to allow coverage by these insured plans. And if you want to use me, you've got to pay some of your own pocket.